Okay, so for the second video, I'm going to go into the case study and the research that they found of the correlations between malocclusion and postural abnormalities in children with mixed dentition. And there was a clinical examination of the oral cavity performed by an orthodontist who recorded molar and canine relationship, crossbite, lower midline deviation, and centric relation, and considering mono and bilateral contacts. Orthopedic examination of the body posture was clinically carried out by an orthopedist who detected abnormalities such as scoliosis, false scoliosis, paramorphism, kyphosis, or lordosis. So materials and methods. What they used is they had a sample of 127 children, 45 males and 82 females of mixed dentition. These were kids that were around the age of 9 years old, pre-puberty, with give or take 8 months in age. They were under good general health, but they excluded patients with previous history of trauma to the maxillofacial, just because with trauma that didn't develop over time and it didn't occur at birth. So it wouldn't be a good representation of the data and how the orthopedics and orthodontics are related. And they completed the orthopedic examination before the orthodontic one. So the screening for orthopedics began with examining the upright position without clothes and without shoes. The screening was measuring the asymmetry of the shoulders, hips, and the obliquity of the pelvis with respect to overhang. It evaluated the alignment of the line joining to the shoulders, to the scapula, and the line joining of the iliac crest. The Brickett test evaluates the ligamentous hyperlaxity of the fingers and of the hands and the different lengths of the lower limbs. The examination was completed with the analysis of the trunk and flexion, analyzing the possible presence of a hump, and therefore the site and entity. At the end, the patient was observed in a lateral upright position for the evaluation of the physiological curves and their possible alterations like kyphosis or lordosis. The orthodontic screening began with recording the molar and canine relationship, crossbite, and centric relation. The crossbite is when, as we discussed before, the top back teeth bite down instead of the bottom back teeth, and it occurs when the top teeth or jaw are narrower than the bottom teeth and can happen on one or both sides of the mouth. Now, centric occlusion and centric relation are different in that centric occlusion is a functional relationship of the teeth, whereas centric relation serves to establish the horizontal aspect of the planned centric occlusion in a maxillomandibular orientation. The reason why centric relation is so important is because it is the highest possible position of the condyle disc in the way it assembles by achieving the coordinated muscle activity when the jaw is closed. At the utmost position, the jaw joints are seated firmly against the bony stop so that they can't go higher. They also examined habits and arches of the class sizes, the arches being angle classification from the overbite, underbite, and class 1, 2, and 3. The habits such as thumb sucking, tongue thrust, mouth breathing, lower lip sucking, and nail biting. They also examined soft tissues because it would be able to detect the symmetry of the face, mouth disharmonies, lip imbalances, perioral contractions, and clinical deviation of the upper and lower midline from the mid-sagittal plane of the face, as well as the occlusal contacts being mono or bilateral. Okay, so the results go into examining patients of severe postural abnormalities, intermediate, and patients with any absent of any clinical objectivity. So they were advised to perform an X-ray examination of the column in its entirety. In 11 patients, the scoliotic curve also extended to the lumbar spine. 4 of them had different lengths of the lower limbs of about 1.5 centimeters, with convexity of the curve on the same side. In 7 patients, an important dorsal scoliosis was present. 87 patients, 26 males and 61 females, were in the original sample, but they didn't consider 7 patients with kyphosis because it was too small of a sample and wouldn't be a best representation of the data. And 7 of the patients were suffering from dorsal scoliosis, and in 2 patients with dorsal scoliosis, there was a tendency of hyperkyphosis and pain during neck flexing, extending, and the left lateral flexing. And the results examining the relationship between types of column abnormalities and orthodontic conditions, they divided them into the same groups of patients with severe, intermediate, and absence of objectivity. In order to examine the results more analytically, that's how they divided them as well. And for each group, the frequency of the orthodontic parameters were taken into consideration, but with, again, the absence of any clinical objectivity serving as a control or normal group. So Table 1 and Table 2 examine the relationship between scoliosis and crossbite, as well as the relation between scoliosis and lower midline deviation in contacts. And to interpret, M and F refer to male or female. RC is interchangeable between CR, it's the cilicentric relation, and the left or right CO and V is a reference to the convexity of the curve either on the left or right side. So these charts show the percentages of posterior crossbites recorded in subjects with structured scoliosis, so 50% of them, compared to subjects with false scoliosis, 25%, and healthy patients, so 33%. The deviation of the lower midline in maximum intercuspation is more frequent in subjects with scoliosis. And the rachis is one of the columns, and it is just the vertebral column or the cord in which it develops, so basically the spine and measuring the curvature. Maximum incuspation refers to the occlusal position of the mandible in which the cusp of the teeth of both arches fully interpose themselves with the cusp of teeth of the opposing arch. This position used to be referred to as eccentric occlusion. And finally, the unilateral contacts in centric relation are more frequent in subjects with false scoliosis, as you can see on Table 2. So Table 3 and Table 4 are a continuation of the data, but Table 3 examines the relations between scoliosis and molar relationship according to English classification. And Table 4 is the relations between differences in the transversal plane and crossbite. In all three subgroups about molar relationship in Table 3, you can observe a very low frequency of Class 3, which is the underbite, and a slight prevalence of Class 2. Patients with false scoliosis and with structured scoliosis, there is a frequent discrepancy between the molar relationship of one side and the other that occurs. This is contrary to what we observed in patients about the abnormality of the spine. Regarding the differences between one or more transversal planes, the most relevant result is represented by the finding of a high frequency of crossbites in subjects with asymmetry of more than one transversal plane, which can be seen in Table 4. From the statistical analysis of the data, we found that the crossbite was more frequent when scoliosis became worse, from normal subjects to false to regular scoliosis. Posterior crossbite occurs in baby dentition or in early mixed dentition and is rarely self-corrected, so it can be hypothesized that this orthodontic condition has a descending role in the onset of postural pathology. So Table 5 is a representation of all the data collected, but specifically with the Pearson chi-squared test. The chi-squared test is commonly used for taking and testing relationships between categorical values, or basically the goodness of fit. A p-value that is less than 0.05 is known as being statistically significant. So this chart shows the crossbite, lower midline deviation, contacts, and molar relationship among the normal, false, and regular scoliosis diagnosis. And the correlation between false scoliosis, and crossbite is evident with a Pearson's R value of 0.279, and it is statistically significant since it has a p-value of 0.002. It is also found that the relationship between left crossbite and contralateral sided deviation of the curve of the spine was in subjects with scoliosis, and it is also statistically significant since it has a p-value of 0.005 and the Pearson's R value of 0.632. We didn't find the same results for the right crossbite, probably due to the small sample size. The deviations of the lower midline were more frequent in patients with asymmetry of the line joining the shoulders and in subjects with deviation of the spine relative to overhang. Moreover, a statistically significant correlation exists between lower midline deviation and false scoliosis, with a value of 0.376 and a p-value of 0.001. The high frequency of crossbites and lower midline deviation indicates that in the samples we analyzed, the crossbite was caused by bilateral contraction of the upper jaw that is responsible for the shift of the mandible on the affected side, which would cause the functional crossbite. Now, this final data table examined the relationship between the difference in transverse planes and the midline deviation. The correlations show a close interdependence between the orthodontic transverse abnormalities, such as the crossbite or lower midline deviation, and those of the spine. It further demonstrates how an alteration of the mandibular posture can influence the neuromuscular kinematic chain of the total body. The kinematic chain describes interrelated groups of body segments connecting joints and muscles that work together to perform movements in the portion of the spine to which they connect. Depending on the difference in level of one or more transversal planes, we do not take into consideration the correlation between the incidence of occlusal abnormalities and the difference of one or more than one transverse plane. The lower midline deviations are frequent in subjects with differences of the line joining in the cingulum scapula humeral. So just a discussion of the results, they found high correlations between crossbites and lower midline deviation in the groups of patients with structured scoliosis and with false scoliosis. The data suggests that the abnormalities of the rachis, again, the vertebral column or the cord in which it develops, is somehow correlated with the malocclusions such as contraction of the upper arch and with the mandibular deviation of the three planes of space. Other research has shown that a unilateral crossbite is associated with an asymmetrical condylar position and with an asymmetrical mandibular opening pattern. This appears to reduce mandibular condylar growth, causing a shortening of the mandibular ramus from the side of the crossbite. It is therefore evident that there is a correlation between scoliosis and malocclusions on the transversal plane, but not on the sagittal plane, and the presence of these types of malocclusions impose a postural evaluation of a patient by an orthodontist. An early correction of the crossbite is therefore desirable because an asymmetric occlusion causes the alteration of the growth that is responsible for the mandibular and facial asymmetry. For this type of correlation, the role of the lower jaw is emphasized with the aim of correct posture of the whole body. So another study is a little bit different than the one that I researched the most, but it examined the genes that regulate the migration of the ectomesenchymal cells and cells of the neural crest that are responsible for the beginning of facial development at around 28 days of gestation. So these genes for vertical and sagittal jaw growth are listed below, and they're involved in the development of the first pharyngeal arch from which facial bones, maxilla, and mandible are derived. And each of these genes has specific developmental responsibilities like developing the jaw, muscle, and tongue, development of the oral ectoderm, migration of the neural crest, and development of the maxilla and mandible. And so during each of this process, if there is a deformity or something goes wrong, then that will, again, create that deformity in the jaw. And the epigenetic and environmental components of this craniofacial development are still largely unknown, but if there is a mutation, that will cause a serious problem. So further research again, the children with a long vertical growth pattern or long face have advanced dental development compared to children with shorter, wider faces. Lip positioning and incisor angulation were increasing along with dental development, indicating that an increased proclination for both incisors and lips. An increased ramus height and lower and anterior facial height impacts the craniofacial complex. The p-values that are shown on the diagram to the right denote a significant level of association between dental development and the craniofacial. Advancement in dental development is associated with a decrease in the sagittal jaw relationship, but is positively associated with bimaxillary growth. A mechanism to explain this is that the eruption and development of the maxillary and mandibular teeth, as well as the growth of the maxillary bone in the vertical direction, will trigger a vertical growth of the mandible. And further studies should explore the effects over time. This was just measured at once. And treatment for any of these cases is dependent on the child and the severity of the case, but the position of premolars plays an important role in the stability of an occlusion. So an early orthodontic treatment could prevent the development of complex malocclusions, especially crossbite. And an early correction of a crossbite is therefore desirable because an asymmetric occlusion causes an alteration of the growth that is responsible for the mandibular and facial asymmetry, and subsequently an asymmetry of the spine. So all asymmetries observed in patients would need a doctor surgery or observation, but you can also break small habits such as thumb sucking or bad posture. That would be like an early onset indication. And these are just further topics to explore on the causes, therapies, treatments, and long-term growth. But that is the end of my presentation. Thanks for listening.